going to talk a little bit about AFib, stroke, and bleeding, a very common conundrum that we encounter all the time in our clinics and our hospital wards. I'm going to review the safety and effectiveness of percutaneous appendage closure, which is a complicated story that involves a lot of data. And I apologize in advance. There's no way around a deep dive into data here. So there's going to be a lot of talk about things like non-inferiority margins. But bear with me at the end. I'm going to try to kind of zoom out and give you some salient clinically actionable points. We'll talk a little bit about the evolving landscape of appendage closure devices. I intend to spend the majority of the talk discussing 4 major trials looking at appendage closure versus DOAC, which is a very hot topic recently. And you can decide for yourself whether you feel there's a clear winner after I show you the data. And at the end, we'll wrap up with a few thoughts about the future, where we're going and whether we can achieve low rates of stroke and bleeding in AFib patients. So I think it comes probably as no surprise to this audience that AFib is growing rapidly. Over the last 15 years, the prevalence of AFib in the United States has more than doubled, and we're on pace for 12 million patients in the US with AFib in the next couple of years. This makes up 5% of the adult population. It's primarily a disease of aging. So by the time folks reach the age of 75 or older, you're looking at 1 in 5 to 1 in 3 even patients with atrial fibrillation. The CHADS VASC, for better or worse, is a very effective risk stratification tool, which has become the dominant risk stratification tool for AFib. These are data from Sweden showing that CHADS VASC score very clearly is associated with the risk of ischemic stroke in patients not managed with a stroke prevention strategy. Point I want to make here is that the vast majority of these patients have an annual stroke risk over 1 to 2% per year, and would be indicated based on US guidelines for some sort of stroke prevention therapy, typically anticoagulation. Stroke itself is a major issue. So 4th leading cause of death in the US, outpaces things like kidney disease, diabetes, chronic lung disease. The good news here is that oral anticoagulation is effective. So these data from the major pivotal trials of DOAC therapy show that the annualized stroke risk on anticoagulation therapy for an AFib patient is roughly 1 to 1.5% per year. The downside is this comes at the cost of major bleeding. So the rates of major bleeding in the pivotal DOAC trials is roughly between 2 and 4% per year. And these are serious events leading to transfusion, sometimes death, disability, or leading into a critical organ like the brain. So for these and other reasons, oral anticoagulation discontinuation is a very common problem. Even in randomized clinical trials, somewhere between 10 and 25% of patients will discontinue their anticoagulant by a year, and these patients have a higher risk of all-cause death and cardiovascular death. What's really sobering is this data from Duke that looks at how patients and physicians view what's important about an anticoagulant medication. What's clear is that patients and physicians both agree that stroke prevention is critical. Okay, that is sort of the low-hanging fruit. What's also clear is that patients are much more concerned about bleeding than physicians are, almost 2 to 1. And what you might consider minor bleeding is a much bigger concern for patients than it is for physicians. And you can see the other questions that I have not circled here also pertain to issues like medication monitoring, how long the medication has been available, the ability for it to be reversed. These are all major concerns from patients. And the truth is that patients are probably right, like most things. So bleeding, especially major bleeding, is associated with mortality with an 8-fold increase in risk. But even things like minor bleeding and clinically relevant non-major bleeding in the Garfield registry were associated with increased mortality. So bleeding is clearly a problem. So you start to understand now this intersection of a growing population with AFib, bleeding risk and stroke risk, which both increase with age. And there's this large overlap of these 3 problems. And this is where this growing need for non-anticoagulant-based stroke prevention is coming from. And so that takes us to the story of appendage closure. It is a long and complicated journey. And I'm going to just briefly show you the timeline here because I think it's relevant, and we're going to go over some of the historical data as well. So a number of devices have been introduced both in Europe and the United States. Some recalled. The Watchman was first introduced over 20 years ago, and it took 10 years for the FDA to approve the Watchman on the back of 2 trials, PROTECT-AF and PREVAIL, and I'm going to go over those. Since then, we've had approval of the Watchman FLX platform in 2020, and then subsequently Abbott's Amulet device in 2021. So PROTECT-AF was really a proof of concept study, the first randomized trial of appendage closure with a percutaneous device compared with medical therapy. The device, the Watchman 2.5, or as I'm going to refer to it, the legacy Watchman device, is no longer available on the market. Okay, this is a early generation device that had its problems. Warfarin was the standard of care back then as well, so the medical therapy has also evolved. Patients were randomized 2-to-1 device to drug. And what was groundbreaking about this study is that for the primary efficacy endpoint of cardiovascular death, stroke, or embolism, Watchman was non-inferior to warfarin. Okay, this was a big deal. It seems obvious now, but at that time, this was a real proof of concept. What was concerning, though, is from a safety standpoint, Watchman was clearly inferior to warfarin in the early days. Okay, so the composite safety outcome is shown here. And if you look at device complications, we're talking about an almost 5% risk of serious pericardial effusion, over 1% risk of procedural stroke, and a 3.5% risk of major bleeding. So these are not the outcomes we see today when a patient goes to the cath lab or EP lab for an appendage closure. What's also concerning in PROTECT-AF is there's this early penalty in the device side for stroke. You see a higher risk of stroke early with the device and a higher risk of stroke later with warfarin. And what seems to make sense here is that there were more ischemic strokes procedurally with Watchman, so there's a higher ischemic stroke risk early, and the warfarin arm accrues this risk of intracranial bleeding and hemorrhagic stroke over time. So the FDA said, okay, this is not enough to prove safety and effectiveness to be on the US market. You need to do a second trial. So that's where PREVAIL comes in. PREVAIL is a smaller trial, almost half the size of PROTECT-AF. Again, patients randomized 2-to-1 device to control, and the concept here was not just safety, but scalability. The FDA wanted to see that this could be done by some new operators, new sites, and that this is a therapy that could be scaled across a large population. So if there were new operators and new sites included. And what's interesting about PREVAIL is that if you look at the event rate for the first co-primary endpoint, stroke, embolism, cardiovascular death, 6.4% with device, 6.3% with control, you would look at those numbers and say, this is actually pretty impressive. First generation legacy Watchman performed almost identical to warfarin. What's interesting about clinical trials, though, is that this actually misses non-inferiority. It's a small trial with a relatively low event rate, and what happens in that scenario is that the confidence intervals around these estimates will be very large. The non-inferiority margin here was 1.75, meaning the upper bound of the confidence interval for this estimate had to be below 1.75 to meet non-inferiority, and it did not. Small trial, few events, the confidence interval reached 1.89, so it missed non-inferiority. Okay, how about the second co-primary endpoint, stroke or embolism non-procedural beyond 7 days? Watchman 2.5%, control 2%. Not bad, small number of events, fairly close. Again, small number of events means a wide confidence interval, missed non-inferiority. So in both co-primary endpoints using relative risk, Watchman missed non-inferiority in this study despite fairly impressive absolute event rates. The caveat here is that the protocol specified that the second co-primary endpoint could also be looked at in terms of absolute risk reduction. So that risk reduction was 0.5%. And if you look at absolute risk reduction as opposed to relative risk, it met non-inferiority. So a lot of sort of clinical trial gymnastics you have to do here to kind of understand this study. But what was impressive, I think, from a safety standpoint, was that major complications were reduced in half. If you look at PROTECT-AF to the continued access protocol, PROTECT-AF to PREVAIL, there was a 50% reduction in major procedural complications. And when you look at the two studies together, the meta-analysis showed a significant reduction in all-cause mortality, probably driven by a less intracranial bleeding in the Watchman arm. So eventually, the FDA, on the backs of these two trials combined, approved the Watchman in 2015 with an important caveat. This was second-line therapy for patients who could not take long-term anticoagulation. And that's where we live today in 2026. Despite these concerns about safety, the procedure grew rapidly. And you can see an inflection point in 2020. So what happened in 2020? This is where we talk about new devices and the evolving landscape. In 2020, Boston Scientific came out with the Watchman FLX device, and this whole procedure essentially changed overnight and became much, much safer. There were a number of design features that are summarized here, but what I'll give you my editorial comment here is that the closing of the back end to reduce the exposure of these metal tines and turn it into a ball formation was absolutely groundbreaking and made the procedure so much safer. And what you see in the data is that overnight, when Watchman FLX became available, the rate of serious adverse events was cut in half. Things like death, pericardial effusion, major bleeding, all significantly lower with the Watchman FLX. These are data I presented at TCT last year showing that with a Watchman FLX, the risk of serious procedural adverse events is less than 1%, regardless of patient's baseline CHADS VAS score. Higher risk patients at baseline do have a slightly higher risk of events, but all of these numbers are less than 1%. Interestingly, if you look at 1-year stroke rates, in patients treated with a Watchman FLX, the baseline stroke risk, CHA2DS2-VAS, clearly has a stepwise association with the residual stroke risk. So if CHA2DS2-VAS is 8 or higher, those patients have a 2.5% stroke risk in a year. But when you look at the anticipated event rate in patients not on anticoagulation, the relative risk reduction you see with the Watchman FLX is very consistent across the baseline CHA2DS2-VAS score at about 80%. So what this means is that patients at the highest risk of stroke, although they have the highest residual risk after treatment with the Watchman FLX, they have the biggest absolute risk reduction. The absolute risk reduction is almost 9% in these patients. The Amulet was approved by the FDA in 2021 on the basis of the Amulet IDE trial. So the Amulet IDE trial is important to understand. This was first generation Amulet, which is currently on the market, compared with first generation Watchman or the legacy Watchman device. And the key findings were that at 1 year, Amulet was non-inferior for major complications, bleeding or death, and for stroke or systemic embolism, so it was approved. Amulet was better in terms of leak. So the rate of 0 leak, a completely dry appendage at 45 days, was higher with Amulet than with Watchman version 1. What was concerning and continues to be a concern is that Amulet had a higher rate of procedural complications compared with Watchman. This was legacy Watchman. And remember, I just told you Watchman FLX was safer than is safer than legacy Watchman. So if you kind of make a 2-step jump there, Amulet versus Watchman FLX, you'd expect this difference would be even larger. But so this has been a concern. Late effusions is an issue. Device embolizations were an issue in the study. There's only one trial that really compares Amulet and Watchman FLX head-to-head. The Swiss Appendage study had 78% or 77% Watchman FLX in the Watchman arm. And as you'd expect in that study, there was a 3-fold increase in major complications in the Amulet arm driven by bleeding pericardial effusion. What's really promising is the next generation Amulet should be out later this year. The Veritas study was published a few months ago, 400 patients treated with this device, and it has a number of design features that we think should make it quite a bit safer. Shortened anchors, dual row anchors to improve stability, and then a recessed distal end screw to have more of that soft conformable ball formation when we enter the appendage. The outcomes of the next generation Amulet study, the Veritas study, were very impressive. So no deaths, no cardiovascular deaths, no device embolizations, less than 1% ischemic stroke and pericardial effusion. So this is a very, very promising step in the next direction. Hopefully this device should be on the US market later this year. So I'll transition now to this topic of appendage closure versus DOAC. And, has a winner emerged? We'll talk about this. So the current landscape of data here is that we have essentially 4 trials looking at this question. 2 are investigator-initiated European studies, and 2 are industry-sponsored studies. And the studies have different strengths and weaknesses. Okay, so the investigator-initiated studies do have a mixed device type. So these are strategy studies. They are not specific device studies. So the appendage closure devices used here is a mixed bag. They are smaller studies on fewer sites. The industry-sponsored studies are large, multinational, device-specific studies relative to the Watchman FLX. So PRAGUE-17 is one of these investigator-initiated studies. It often gets overlooked because it's a small study, 400 patients, but it actually very much reflects the kinds of patients we see in current US practice, high risk for bleeding and stroke. CHA2DS2-VAS is almost 5. Randomized 1-to-1 appendage closure versus DOAC. And if you were going to set up a fight for appendage closure to lose miserably, this is how you would set it up. So there's only 3% Watchman FLX here. There's 61% first generation Amulet, 36% legacy Watchman. Legacy Watchman is not on the US market, and the US market is not 61% Amulet. It's a majority Watchman FLX. On the flip side, the DOAC arm is 96% of apixaban, arguably the safest oral anticoagulant medication we have for stroke prevention and AFib. So the primary composite is a mixed bag of both bleeding and ischemic outcomes as well as procedural complications. And at 4 years, despite somewhat of an unfair fight, appendage closure was non-inferior to DOAC. So impressive data. There are criticisms of the study in terms of sample size, non-inferiority margins, and the mixed composite of ischemic and bleeding outcomes. But as it was designed, appendage closure here was non-inferior to 4 years. CLOSURE-AF has a very similar design. It was recently published in the New England Journal of Medicine and got a lot of attention. So you can see headlines like this: LAAO doesn't match medical therapy for high-risk AF patients with closure and AFib. So let's go over that data. So this was 900 patients, randomized 1-to-1 to appendage closure and medical therapy. The primary endpoint, similar to PRAGUE-17, is a mixed composite of stroke and bleeding events. Okay. The primary endpoint, for the primary endpoint, appendage closure failed non-inferiority compared with physician-directed best medical care, which was mostly DOAC. And again, this is a strategy study, not a device study. So what you see is that in the appendage closure arm, again, a minority of Watchman FLX, a majority is a mix of other things, legacy Watchman, Amulet, Lambre device, which isn't available in the US, and some other things like failed implants. In the medical treatment arm, the majority, 84%, had DOAC with or without single antiplatelet therapy, a very small number of patients who had warfarin, antiplatelet therapy alone or no therapy. Another lesson from CLOSURE-AF here is that procedural safety in this specific endeavor is extremely important. This is a preventative therapy, and a small number of procedural events can very quickly tip the balance from superior to non-inferior to not non-inferior. And so if you look at bleeding events in this trial, the device arm had 70, the medical therapy arm had 61, 18 of the device arm bleeding events are procedural. And when you look at the procedural complications, they're higher than what you would expect in current US practice. Major bleeding, 4.3%. And remember, I told you that a PROTECT-AF study done 20 years ago with legacy Watchman, major bleeding was 3.5%. Okay, so this is higher than the rate seen in the PROTECT-AF. Pericardial tamponade was over 1%. That would be unheard of in that current practice today in the US with the predominant Watchman FLX. So let's transition now to the industry-sponsored trials. Option was really the first trial of the Watchman FLX versus DOAC. It was in the context of patients being treated with an ablation for their AFib, which is an important caveat, but it was not a trial of concomitant ablation and appendage closure. Most of the ablations in this procedure were actually done sequentially, not in a staged manner, not concomitantly with the appendage closure. The main question here was Watchman FLX versus DOAC in patients receiving an ablation. Primary endpoint was death, stroke, or systemic embolism at 36 months. And the second primary endpoint for safety was non-procedural, major or clinically relevant non-major bleeding at 36 months. For the primary endpoint for efficacy, Watchman was non-inferior. And for this bleeding safety endpoint, again, Watchman was superior here with hazard ratio 0.44. When you look at major bleeding, a secondary endpoint, which included procedural bleeding, there was no significant difference between the two arms, and this met a criteria for non-inferiority for major bleeding, including procedural bleeding. So now that brings me to CHAMPION-AF, also published in the last month and presented at ACC last month. The largest trial to date of the Watchman FLX compared with DOAC, 3,000 patients, and you look at that sample size compared with the previous LAAO trials, you can see that it outpaces everything else by almost a factor of 2. 3,000 patients randomized to Watchman FLX and DOAC. 5-year follow-up is planned. We have outcomes at 3 years now for stroke, systemic embolism, cardiovascular death, and for the second outcome of a non-procedural major, clinically relevant non-major bleeding. So for the primary outcome, Watchman was non-inferior with a hazard ratio of 1.2, p less than 0.01 for non-inferiority. And we're going to come back to that in a second. There is some degree of controversy around that we should talk about. Non-procedure related bleeding, Watchman was clearly superior to anticoagulation. If you look at major bleeding, including procedural bleeding, what you see is what you would expect from the logic and from what we see in practice. There are more bleeding events early in the patients who are treated with a procedure when you factor in procedural bleeding. That risk tends to cap early on and has a very flat growth trend later. And the risk of bleeding with anticoagulation continues to accrue over time out through 3 years. And then this met criteria for non-inferiority. So let's go beyond the primary endpoint for a little bit here. So the good news on the Watchman side here is that there were actually a substantial number of crossovers. So the majority of these 13% of patients who crossed over from control, from DOAC to device, actually crossed over with no clinical indication to cross over. So physician or patient wanted one patient to have a Watchman FLX and they got it. And so there was a lot of crossover of the Watchman arm. Procedural safety was outstanding in the CHAMPION trial. The bad news is that at 4-month imaging, there was almost 5% rate of device-related thrombus, over 21% risk of leak. When you look at ischemic stroke at 3 years, the number is numerically higher with Watchman 3.2% versus DOAC 2%. Major bleeding was really no different. And so the major difference here in terms of bleeding was driven by clinically relevant non-major bleeding. Let's take a little bit of a closer look at CHAMPION and CLOSURE-AF, which were 2 trials that came out around the same time and really had sort of opposite findings. So it's important to kind of understand some of this. So CLOSURE-AF screened over 10,000 patients over 6 years to enroll 8% in that population. So it was a very hard trial to enroll. The sample size was substantially lower than planned. The sample size was planned to be 1,500, ended up at 900 patients. So they enrolled 42% fewer patients than planned and 40% fewer primary endpoints. So whether this trial was adequately powered is a question. And they had the strictest non-inferiority margin to date in the LAAO CLOSURE trial, 1.3. On the flip side, Champion included 93% of the patients that were screened. But there is some controversy around this sample size and the absolute event rates here. So the expected event rate in the control arm was 12%. And based on this and using a relative risk of 1.4 for the non-inferiority margin, the non-inferiority margin was set at 4.8%. What was observed was an event rate in the control of only 4.8%. So if you use the same relative risk of 1.4, the absolute risk that would have been non-inferior would have been 1.9%. But because of the trial protocol going with the original expected event rate and using an absolute risk of 4.8% as the non-inferiority margin, Watchman met non-inferiority. But there is a criticism that had the relative risk or the hazard ratio been used instead, the primary endpoint actually would have missed non-inferiority. So this is where some of the controversy around Champion F comes in. I would say that there are methodological concerns on both sides here, and how you look at these data is a little bit hard to reconcile. So my take home from these studies is that ischemic stroke annually with a DOAC seems to be between 0.5 and 2% per year. It's not zero. With appendage closure, that rate numerically is a little higher. I estimate to patients 1 to 2% per year, but very similar and statistically similar to Champion. Major bleeding is a continuous hazard over time of DOAC and clearly an early hazard with appendage closure. Procedural complications vary by device type, and there is no class effect for safety right now in the United States with appendage closure. So which device you get does have an influence on your procedural complication risk, and there are some long-term concerns we're going to talk about. So in the future, last 2 minutes here, we'll chat about, can we achieve consistently low rates of stroke and bleeding in AFib patients? That's really the goal here. And there's a few things that we need to kind of flesh out more to do that. Despite a wealth of data in this space, and I showed you a lot of data in the last 10 minutes, we really don't understand a lot. So device-related thrombus prevention and management is an area that's got a critical need for more data. Peri-device leak and its impact on stroke risk is an important issue. And there's more and more data coming out now that rhythm control in patients with AFib may influence their stroke risk. The long-standing conventional dogma that patients have a consistent stroke risk in sinus rhythm or AFib, and we don't regard that as a stroke protective factor, may be going out the window. I had the opportunity of the last couple of years to sit on this combined effort between Sky and HRS to produce a technical review to support the 2025 guidelines. And so we did an exhaustive review of the literature on 8 key clinical questions pertaining to patient selection, imaging, DRT management, leak management. And I show this to say that what's really humbling here is that we really only have RCT data on 1 question, 1 out of 8. And it's 4 now. We have Champion AF. No, we didn't have it at the time, and we have option as well. Actually, I guess I should say 5. But there's no randomized data on any of the other topics. And all we actually have is a very small number of non-randomized studies with a high degree of uncertainty and bias. DRT, I would still say, is the Achilles heel of this therapy. So the rates of DRT range from 1 to 5%, depending on the trial that you look at. And what's really sobering about the Watchman FLX data from Champion is that the prior Watchman FLX studies that showed a DRT rate of about 1%, now we're at 5%. So trying to understand that is going to be really important. This is our data from St. Luke's. We found a DRT rate very similar to the DRT rate of Champion in long-term follow-up. Most of these are identified, however, within the first 6 months. Prevention of DRT is also a mess, to be honest. We have no consensus in the United States on what medical therapy should be given to a patient after implantation of an appendage closure device. The options are all over the board. There are multiple drug regimens approved by the FDA, which we can discuss. But we will have the simplified trial coming out hopefully soon to give us some clarity. This is a study of over 1,800 patients with a successful implant of a Watchman FLX randomized to 3 arms. Aspirin monotherapy, which is a provocative concept to just put the Watchman in and put them on aspirin. A half-dose DOAC for 3 months, or dual implant therapy for 6 months. Peri-device leak is also a very hot topic. at any meeting in the last 3 years, management of leaks, whether to close them, whether to leave them, whether to anticoagulate patients, this is a constant debate in the field. The reason is that it's an ongoing problem. So even in the most contemporary Watchman FLX studies, the rate of peri-device leak of some degree is roughly 15 to 20%. CHAMPION-AF was 21%. The current generation Amulet device is not necessarily better than that. The next generation Amulet device, maybe, we will see. But this is a space that has allowed a lot of new devices to come to market and to iterate. So there are novel devices coming. I've shown you 2 here, the class Accuform from Conformal, which is now acquired by Gore Medical. We were in that study. And the laminar device, which is managed by J&J. So these are 2 devices that are centered really conceptually around the idea that we need complete closure of the appendage with no residual leak. The challenge is that even in the early feasibility experience from these studies, the leak rate is not 0. It's somewhere in the ballpark of what you'd expect from a Watchman FLX. So have we moved the needle? I'm not sure. And have we done it at the cost of safety? That remains to be seen in these big pivotal trials. The next generation Watchman is going to be in a study later this year. The Watchman Elite device will be in the Elite AF study. This next generation Watchman has an increased number of struts and anchors, and rather than a tapering body conformation, has a 0 tapered body, which we think may help with CF. Remains to be seen. Okay, a little bit about rhythm control. So there are 2 really important studies that I think folks should know about that were presented last year and now published. The Alone AF trial, low risk patients, no recurrence 1 year after an AFib ablation, CHA2DS2, 2, randomized to continuing anticoagulation or stopping it. And you can see that no anticoagulant was actually superior to anticoagulant, driven by less bleeding. Another trial, the OCEAN trial, very similar design, low-risk patients, CHA2DS2, 1 year, no recurrence after AFib ablation, randomized to aspirin or rivaroxaban, no difference in the risk of stroke, including MRI adjudicated events or embolism 3 years. What's also interesting here is if you plot the CHA2DS2 as a population and the annualized ischemic stroke risk after appendage closure for most appendage closure studies, they follow a very clear line. The one outlier is option. And what was different about option? Option patients had an ablation. If you look at the annualized ischemic stroke risk after Watchman FLX in the option study, it was a third almost of what we saw in CHAMPION. So it sort of brings up the question, did the ablation confer some additional protective effects against stroke? And so this is now a rapidly growing concept that appendage closure and ablation should be combined and done together. This field was growing even before CMS approval for payment, and now CMS approved payment 2 years ago, and it's really taken off. Imagine briefly a world here with 3 different patients. Okay, on the left, a very high-risk patient for stroke and bleeding. In the middle, an intermediately high-risk patient for stroke and a history of fall risk. And on the right, a patient who's got an indication for anticoagulation, but is low bleeding risk and has symptomatic paroxysmal AFib. So in 2023, the patient on the left would typically be offered an appendage closure. In the middle, potentially a staged ablation and then an appendage closure given the fall risk. And on the right, straightforward, just an ablation and standard anticoagulation. As of last year, you can make the argument that the patient in the middle should be switched to a concomitant procedure. Do them both at once if you're going to do them. And where the field seems to be headed is that in the future, maybe the patient in the middle and the patient on the right should be offered an appendage closure and an ablation. And so you can see in this kind of fictional universe of 3 patients, the number of appendage closures has gone up, but the number of standalone appendage closures has gone down as concomitant procedures with ablation and appendage closure defined grow rapidly. Okay, I want to close with a recent patient experience with a true story. 67-year-old patient I saw in clinic several years ago. He came to me with a diagnosis of permanent AFib, CHA2DS2 3. I saw him, I guess now 4 years ago. At that time, he couldn't afford DOAC, so I switched him to warfarin. I said he's a low bleeding risk. He doesn't have an indication for appendage closure. Warfarin is associated with a higher risk of intracranial hemorrhage, and this gentleman had a fall, had an intracranial hemorrhage, and after a long and complicated course, was cleared for short-term antithrombotic therapy. He had very favorable anatomy for appendage closure. Brought him in, did a Watchman procedure. It took 25 minutes. He went home the same day. End of the year, he's doing fine. Off of anticoagulation on aspirin, no DRT, no bleed. And so my prediction for the future is that patients like this will be offered what is hopefully a very simple procedure that's ICE guided. We didn't talk about ICE. We can. People have questions with very good results. There's a lot of new devices coming in this space, and my prediction is that in 10 years, only the safe devices will survive. This is a preventative therapy, highly elective, and the major adverse event rate has to be less than 1%. I think patients like my patient will have better options in the future and hopefully safer options. There's an evolving role for combination therapy in extremely high-risk patients. Maybe treat them with appendage closure and medications as long as they can tolerate it, rather than one or the other. Think about how we manage heart failure, how we manage coronary disease. It's device plus drug. It's never device or drug. Risk prediction will get much better. CHA2DS2-VASc has been very useful, and I have nothing bad to say about it, but I will say we can do better, or at least AI can do better, and I think we'll be there in 10 years with better risk prediction tools. Rhythm control is clearly picking up. And, I leave you with the question of in 10 years, can we be achieving consistently lower rates of stroke than 1% and bleeding lower than 2% in the population? If we can achieve that, we'll have made a major impact on the lives of patients with AFib. So I'll stop there, and thanks so much for your time and the invitation to give.
Oh, that's learning a lot. Couple questions. Would you go so far as to say, irrespective of age, a person who is at extremely low risk of bleeding should stay on pharmacology and not go to mechanical device closure? 50, 60, 70, 80-year-old at low risk of bleeding, if they're tolerating it and their epidemiologic descriptors predict that they're low risk, keep on drugs.
So it's a great question. So that case I showed highlights a very important, I think, observation that patients' bleeding risk is not static. It changes rapidly. They're low risk until they're immediately high risk. And so my answer to that question is that anatomy, I think, will drive a lot of this in the future. There are certain appendages based on the orifice and the elliptical nature of it or whatever that are very prone to leaks and problems. And there are certain appendages that you look at them and say, this can get a Watchman in about 10 minutes and we're going to get a nice result. And I think we'll be better at predicting that over time. And I think just like we've seen in fields like TAVR, mitral, anatomy should really just drive what options low-risk patients have. The same way not every low-risk patient I treat with TAVR, not every low-risk patient goes through surgery. I think not every low-risk patient is going to have one option, appendage closure or anticoagulation.
I was glad you brought up the part about, ablation and the impact that has, because I think all too often if it's just an interventional cardiologist doing the procedure, they don't think about ablation. 2 hospital systems in Arizona. One has great ablationists. They do almost no Watchman. Another one, ablation doctors are good, but I think they're the highest, Patrick, I think they're the highest Watchman group, as Patrick McCoy, like that. Top 10 Watchman groups in the nation. How do you bridge that? That's absurd. We do all Watchman, we do all ablation, and it's just they're so far apart. And like Patrick said, they're one of the top 10 because they don't do that many ablations. They're one of the top 10 Watchman programs in the country.
Yeah, so this is a really tough problem. So I'm an interventional cardiologist, so I don't do ablation. And,
But obviously you think about it.
But I think about it, and I have no problem sending a patient across to my ED colleagues to do concomitant. In fact, one of my patients today is getting a concomitant closure and ablation by one of my partners. That is ideally how it should be done. That we, if the day comes when we don't need interventional cardiologists to close appendages, I've got lots of other things to do. Dr. Garcia showed a whole bunch of devices I can put in, but I don't think we're going to get there. And I'll tell you why. The current population we're treating is tip of the iceberg. And those folks who need standalone appendage closure, patients with permanent AFib who are 85, 90 years old, have severe TR, they'll still be very appropriately treated by an interventional cardiologist. As the field grows, it's going to grow into this low risk combined ablation appendage closure group. And I have no problem with sending all those folks to EP. That's what they need. And if we keep the focus on what the patient needs, not what the doctor needs, we're going to be doing the right thing.
That was really fantastic. Good discussion. Anybody else?
Just I would say rather than competing with EP, I think we need to learn from EP. I would be thinking is why can't we replicate the model for mitral appendage closure at the same time? and TMBR. That's what the patient will get if they go to surgery. But if you send a patient to surgery with much valve repair, much valve replacement, in all likelihood, the patient will come out and get one with no appendage.
Yeah, there's an interest, I think, in this concomitant procedure on the interventional side with mitral, as you say. I'll give you my bias. My bias is that I know the Watchtower trial was done and it did not have the best results, and so that field has sort of been, left alone. But I see so many patients in our valve clinic. They come with a CT, they have AFib, they're older, they're frail, whether it's TAVR or tricuspid tier. Both of those would be wonderful populations to be able to offer concomitant procedures to.
All right, guys, we're excited. We got a follow-up discussion on a fantastic talk from Arch with Dr. Chetan Huded, who's the Associate Director of Structural Heart at Mid-America Heart, and is really kind of a master of all the clinical trials in LAAC, gave a really nice overview of these trials. And I think our goal today is just kind of take the summary from that and kind of move forward with a catharsis in that how do we manage patients who are presenting to our clinics, seeking left atrial appendage closure. So Chetan, thanks so much for joining us today, buddy. I really appreciate you being here.
Yeah, thanks for having me, Joe. It's nice to be here. So, the talk at Arch was kind of an interesting time for appendage closure because we were at a little bit of a crossroads, with Champion AF and CLOSURE-AF both being published. That's kind of what we talked about, at the meeting.
Yeah, and I think it's really interesting. We now have 4 trials, which you've nicely summarized in this slide here, showing some kind of mixed results going both ways for LAAC versus just DOAC and atrial fibrillation. So I'd love it if you could just kind of walk us through the trials, just as a quick summary, and then we can talk a little bit about kind of your catharsis in terms of how do you manage some of this data, given that it's a little bit discordant, and how do we have that shared decision-making conversation with our patients who present for left atrial appendage closure?
Yeah, sure. So I break the trials down into sort of 2 camps, as you can see here. So there's a total of 4 randomized trials that really compare appendage closure versus medical therapy, or you could even say versus DOAC. So there's 2 that are investigator initiated. That's PRAGUE-17 and CLOSURE-AF. And there's 2 that are industry sponsored by Boston Scientific. Those are Option and Champion AF. And both categories have pros and cons, to be clear. So investigator-initiated studies oftentimes have, the perception of sort of less bias in terms of study design. But there are also some issues in terms of generalizability, right? So both of these were European studies. They used a mixed kind of approach to appendage closure. So it's really a strategy study, appendage closure as a strategy versus medical therapy as a strategy. These aren't trials of a specific device. What I talked about at Arch is that if you look at the device types used in these investigator-initiated studies, like I said, it was a mixed bag. So there was a minority of Watchman FLX, even in CLOSURE-AF, and it's a majority of other things, Legacy Watchman, Amulet, Lambre, other things. And so you'd have to just think: is that reflective of your practice at your site? Is that how appendage closure is done in your hospital in the U.S.? Maybe, maybe not. These also tend to be smaller studies, right? Because big studies means a lot of money, a lot of funding. And so these tend to be slightly smaller studies in terms of sites and participants. So on the investigator-initiated side, PRAGUE-17 has 4-year outcome data, and it was considered a positive study. So appendage closure non-inferior to medical therapy. Majority of the medical therapy arm in that trial was apixaban. In CLOSURE-AF, as has been well documented now, both, in the popular press and at meetings, is that appendage closure missed non-inferiority. So it was not non-inferior to medical therapy, the majority of which, again, was DOAC, like 85% DOAC. And the industry-sponsored studies sort of tell a different story, right? So these are larger global studies, more sites, more participants, and they're device specific, right? So both of these trials were 100% Watchman FLX. So that has, again, pros and cons, right? So on the pro side, there's that, if you use Watchman FLX and you want to know how does the Watchman FLX compare to DOAC, well, this study really, answers these studies address that question. But if you're the kind of person who says, like an industry sponsored study is going to be biased in terms of the endpoints and so forth, well, yeah, those concerns exist as well, right? So, So, there's two sides to this coin, obviously. So both Option and Champion AF were, positive studies. And as I kind of went through in the, in the presentation, and hopefully people can watch that, there is some concerns methodologically about how non-inferiority was handled, in Champion AF, and that by virtue of using an absolute risk reduction as opposed to a relative risk ratio for non-inferiority, the endpoint was overwhelmingly positive for non-inferiority. But had they used relative risk, maybe it wouldn't have been. And so that's a concern. There's also some concerns about the bleeding endpoints that were used, in terms of was procedural bleeding used in the primary bleeding outcome or not, and so forth. And so I think those are all valid things that people need to look at. If I'll go to the next slide here, there's so much data, and it's like this field now is really kind of stuck in these weeds of non-inferiority margins and like bleeding definitions and endpoints. And so we're really down into the kind of the nitty gritty. And so it's going to be an interesting time, at the FDA and CMS as they kind of struggle with this and decide, should LAA closure be frontline or not? And I'll tell you kind of my take-home points from looking at these data and other data, that like kind of what I talk with patients in the clinic about is that with either approach, your risk of an ischemic stroke never goes to zero, unfortunately. It seems like sort of an obvious thing, but it's worthwhile kind of reminding patients that like nothing is completely preventative of stroke. With
Absolutely.
a DOAC, your rate is somewhere between 0.5 to 2% a year. And with LAA closure, it seems to be, numerically a little bit higher in a number of trials now, not just in Champion AF, but in some of the older Watchman studies. So I quote like 1 to 2% a year. And I do tell them like it might be slightly higher than with DOAC. In terms of major bleeding, the rates are actually very similar in the trials, but what you see is that the DOAC arm has this continuous hazard that accrues over time, and the appendage closure arm has an early hazard that tends to be mostly procedural in the first few months when they're still on antithrombotic therapy, and then it tends to level off. That's how the KM curves look, and that's what makes sense clinically as well. In terms of procedural complications, obviously appendage closure has them, but it really varies by device type. And we went over this in the talk, depending on what device you use to close the appendage, the complication rates are highly variable. And so I'm a strong believer that currently we don't have a quote unquote class effect for safety in appendage closure. You can't just say I'm going to close the appendage however I want and it's all going to be the same. I don't think that's true. But the good news is that as we move into like second, third generation devices, the Watchman FLX, the next generation Amulet device, they all are showing improved safety. And so I'm optimistic that we will get to a phase where we have multiple devices that are very, very safe. But right now in the US, I think the safest device clearly based on the data is the Watchman FLX. And then there's long-term concerns on both sides, right? So if you're a patient who, has had a bleeding history, certainly they are worried about this continually accruing risk of major bleeding year over year. And so on DOAC, this long-term bleeding risk remains a major issue for my patients. With appendage closure, I think we have to be honest. DRT and leak are long-term issues with the device that we still don't totally understand. There's like an amazing dearth of data on how to manage these issues. And if appendage closure is going to move into that first line role, we just have to get answers on things like that, on DRT and leak, and we need more data on how to manage them and how to prevent them. So these are the things I talk about with patients in the clinic. It's actually a pretty lengthy consult usually to get someone to a decision that they feel good about and I feel good about, but it's worth doing all this up front rather than you put a device in and have to have a conversation after the fact. So
I think this is such a great summary, Chetan, of really the key components of a shared decision-making conversation with patients. And so first question I would have is, are you, when you see patients in clinic who are you're evaluating for LAC, are you splitting them up into different kind of phenotypes based on the literature? So you've got your, patient that's bled, right? So your patient that's had a GI bleed or some sort of intracerebral bleed. Then you've got your high stroke risk patient that maybe hasn't bled, but has a reason to seek an alternative, such as, nuisance bruising, bleeding, such as that. And then lastly, kind of you're straight down the middle, CHADS 2 VASC 3 or 4, is no history of bleeding whatsoever, but the patient just doesn't want to be on Eliquis for the rest of their life. Or are you kind of approaching every patient the same way and just discussing the data in a slightly different attempt? So how are you approaching these patients?
Yeah, it's a good question. So I think what your question kind of alludes to is that, it's not a binary thing, right? So appendage closure candidate or not is very much on this sort of spectrum, right? So there are people that don't want to take anticoagulation and have like a reasonable reason not to be on it, but probably could safely take it. And there are people that have had spontaneous intracranial bleeds or, like cerebral amyloid angiopathy, these very high risk conditions that make everybody, including me, uncomfortable with long-term anticoagulation for them. And so I try to figure that out, right? And that's kind of one. And then that part of it is there. And then the other part is their LAA anatomy. So I'm a big believer in pre-procedural imaging. And what I tell a lot of patients is, if your anatomy is very straightforward for a device, for a Watchman FLX, and it's the kind of thing where we can put a device in 20 minutes and you'll be home the same day, I'm much more willing to kind of treat earlier on this disease spectrum, closer to that kind of low risk side. If your anatomy is very difficult or very elliptical or lots of proximal pectinates or, things like that make it complicated or, more challenging to get like a really nice complete closure, I'm willing to do it for sure if you have a definite need. But if you're on the low risk end of the spectrum, it's sort of this question of, do you really want to go down this road? And so I oftentimes have that conversation with patients after I get their imaging back of, making sure that they understand kind of where they are on both of these spectrums, sort of clinical and anatomic.
I love that. No, I think this is certainly going to change the way I approach my conversation with patients. And I think you also have to approach the conversation knowing what level of insight the patients have. Like, I still have a lot of patients that think the Watchman's going to get rid of their AFib. And so I have to spend a good 10 or 15 minutes just talking about what AFib is and why it increases their stroke risk and what the procedure entails. And then I like to get into kind of the trials, what the trials show, talk about their risk of bleeding, really dig into that a little bit. In terms of procedural complications, my approach with Watchman FLX is that, it's a pretty low risk procedure. It's one of the lowest risk procedures I do. And I think that's one reassuring thing about the data is that, this remains a very low risk procedure. So that part of the conversation is a little easier. It's really just a function of long-term outcomes in terms of what is their bleeding risk, what is their stroke risk, what is their specific reason for wanting to get off anticoagulation. So what do you think kind of a best practices would be for a consent shared decision making for LAAC? Like, what are the key components that you really try to hit on when you talk to patients?
Yeah, that's a great point. So I always hit on procedural complications, and I am very specific about the device I'm going to use. So I get referred to a bunch of patients who've had a failed Watchman or something, and they're referred specifically for a first generation amulet, and then I quote a different number for procedural complications with that. So I'm very specific about that. I always talk about pros and cons of sort of general anesthesia TE versus if we're going to do ice, I kind of quote them something different for that. And then I always talk about DRT and leak. I just think it's important because, especially DRT, patients have this procedure done so they don't get a clot in their heart and they don't have to take blood thinners. And if they get a DRT, they have a clot in their heart and have to take blood thinners. And that risk we're seeing is anywhere from like 3 to 5%. And so if you do enough of these, like, you're going to have a bunch of these patients with DRTs each year. And so I think it's really important to make sure that's covered in the consent. What's challenging about this whole thing, to be honest with you, Joe, is like, because of the language around CMS shared decision making and that it's by a non-interventional physician, there's just like so much uncertainty about who's going to have this conversation with the patient. And I do still meet my patients in the clinic for the most part. There are some patients I meet in holding the day of the procedure, but for the like 95% I meet them in clinic. So I do all this. The frustrating part is that doesn't technically count as shared decision making, right? So then I have to also get, like a letter from their primary or their referring cardiologist, and it just creates this kind of like multi-step process. So I would love to see that part of it cleaned up a little bit, or maybe a little bit like leaner in the if the NCD gets changed. But I think it's essential to have these conversations. It would be nice if like the interventional team was that conversation counted, so to speak.
It would be nice if CMS trusted us to actually be a good doctor and tell our patients what they need to know. So are you using CHADS 2 VASC and has bled to quote them specific percentages in terms of the risk of ischemic stroke? I mean, do you think this lends itself to some sort of algorithmic approach in terms of what a shared decision-making conversation should look like as a patient-specific conversation based on their individual risks? 'Cause it seems like we have enough data to give patients kind of that specific information. Now, whether most people are sophisticated enough to use that, is another question. But I mean, do you personally use their CHADS 2 VASC and has bled to say, hey, this is your yearly percentage risk of stroke, this is your yearly percentage risk of bleeding, we put a Watchman in, this is, so does that factor into your conversation?
I give them buckets, so I'll say if it's a higher stroke risk patient, I'll say 5 to 10% per year, and if it's a low stroke risk patient, I'll say like 2 to 5% per year, just to avoid kind of overwhelming them with like specific no. But to your point, so I actually, I presented this data at TCT last year. I did an analysis with Boston. We looked at the SURPASS registry, which is, is like thousands and thousands of Watchman FLX implants in the United States, and we wanted to get this exact data, which is what is the procedural complication rate by CHADS VASC, and what is the residual ischemic stroke risk by CHADS VASC. And so we have all that. It's under review now, so hopefully it'll be published soon. But it's a great data source to actually then use in shared decision-making conversations. So to say, okay, your CHADS VASC is 5, I think that corresponds to an annual stroke risk like somewhere like 6-7% or something. Okay, with a Watchman FLX, your procedural complication rate is like 0.7, and your annualized ischemic stroke risk with the device is 1.3. I'm making these numbers up, but it's somewhere in these ballparks. So so that data, hopefully we'll have published later this year and people can use. I think it gets back to what you said before. It depends on your patient, right? You kind of have to read the room. And so some patients want that level of data and will come with like, the whole notebook full of questions. And I always make sure the notebook is emptied by the time I'm done. Like I make sure that every question is answered. I had one person actually bring like one of those brochures and, that has like the asterisk with like all the complications. And we went one by one.
Oh my gosh.
One by one. I just think it's so important.
Definitely an engineer. That was definitely an engineer that brought the notebook. Yeah.
And then there's people that are like, I don't want to know. Just tell me, like, is it a good idea? Is it a bad idea? Is it risky? Is it not? And I always try to pull them back into the conversation to say, I can't tell you to do this, but like, I want to work with you.
Yes.
But then I will simplify things a little bit and try to make it more general and less, and try not to overwhelm them.
The question I fear the most with this procedure is when they ask me, what would you do if it was your mom or dad? And I'm always like, I can't, I would tell them to make their best decision, right? Because like, I'm not a 70-year-old guy that just had a GI bleed 6 months ago. So it's a little bit hard for me to extrapolate.
Well, so many people say that. I've started leading with it. I actually will start closing my closing remarks with, if you were my brother or you were my dad, this is what I would recommend. So because people it just brings the tension in the room down. People are like, oh, okay, well, he cares about me individually as a person and is like understanding that I have choices and stuff. So I've tried to kind of use that actually because I realize like so many people just want to know that question. What if I was your family member, if I was your loved one, would you do this? And I try to tell them, this is what I would think about,
I love that. Last question that I have, Chetan, are there any, because, I have this theory that the EPs are doing kind of the lower risk, kind of healthy, well patients because they all have like paroxysmal AFib and they're seeing them. And we're kind of getting relegated to kind of the higher risk patients with major bleeds and older generally. Are there patients you see in clinic that you will not do a Watchman on in terms of age, comorbidities, maybe even a super low risk patient? Is there any patient where you look on your clinic schedule and you review their chart and you're like, nah, I don't think this patient needs it. Like
I've turned down a couple people so, I mean, we have to kind of remember that the whole basis of the therapy, right, is that the majority of your stroke risk comes from the appendage. So I actually had, like a great example. I had a patient on the table on Friday. We had kind of an old CT, and I said it was fine, and we got to the lab, and I still like TE, so we did TE, and there's this like atrial septal aneurysm like popped out, like one of the tops of those like McDonald's soda caps that has a little button that pops, like that thing. It popped over to the side. It was like sitting there and it created this pouch and there's like smoke swirling in the septal aneurysm. And so I just canceled. I said, this is probably a higher risk for a stroke than the appendage. So you have to, I think, always like be a doctor first, right? So look at the atrium. The atrium is like so massive and has smoke swirling everywhere. I don't know that it's logical to think like closing the appendage is going to be helpful there. So like there's these kind of like one-off cases. And then on the low risk side, I am, I'm pretty proactive about sending patients to my EP colleagues to get a concomitant ablation and appendage closure if I think they need an ablation too. Like I get a lot of people from the hospital like new AFib and had a GI bleed 6 months ago. We don't want to start them on apixaban. Go see Huded about an appendage closure. And I see them and I say like you had new AFib, your EF came down a little with the AFib. If I were you, I would get a concomitant. I'd get a PFA and appendage closure. So, so I'll do a CT. I'll make sure your anatomy looks good and go see my partner. And so I'm pretty proactive about that because my feelings at the end of the day, there's enough appendages to close. Like let the EPs do the ones that need the rhythm control, and all of the patients, like you were saying, kind of the older frail patients with permanent AFib and so forth. Like those patients will be there for us to close. And so, it takes a certain like practice structure to make that like a viable option, but I'm hoping that that's kind of the world we live in, where people are like willing to send patients away if they need someone else's skill set.
I think that's a really thoughtful observation, Chetan. I think we really need to be cognizant of the patients that do warrant, a PFA and a concomitant, because, we don't want this to turn into one of those therapies where it's just, interventional cardiologists throwing Watchmans in everybody. We really want to
Right.
be thoughtful about it. So I think that's a great observation. And this is a great framework to work from when you talk to patients, is this final slide that just kind of summarizes the data. So thank you so much, man. This was great. Closing thoughts. I think that, we really need to be thoughtful about our shared decision-making conversation with patients in light of the new data we've gotten from Champion, as well as some of the investigator-initiated trials that Chetan reviewed here. So I would use this slide as a foundation for talking to your patients. And again, thanks for your time and thanks for your expertise, Chetan. Always great to have you on MurmurMD.
Yeah, thanks, Joe. Appreciate it. Thanks for having me.